Good morning, everyone. Good afternoon as well. My name is Dr. Griffin Myers. I am our co-founder and chief medical officer here at Oak Street Health, and I am delighted to be on behalf of our team and our colleagues in Rhode Island hosting this webinar. I'm going to go ahead and get started. The way that these webinars work is a little bit tricky at times, so if you have any questions or concerns, technical issues, please type that in the chat. I'm taking a look at that, and we'll make sure that we address those items as they come up. But to begin, I want to start with a few just quick disclosures. Number one is I am adjunct faculty at the Northwestern University Feinberg School of Medicine, as well as the Kellogg School of Management, also at Harvard Medical School, and obviously I'm a co-founder and chief medical officer here at Oak Street Health, who is my primary employer. But I think before we jump in necessarily to agenda, I wanted to quickly introduce myself by saying I am an emergency doc by training. Got into that field because I was interested in this idea that I could take care of patients whether or not they could pay me. Loved it, despite having passed out cold the first 2 times I went into trauma bay, but overcame that, and pretty quickly into my career as an emergency doc recognized that what people need rather than high quality emergency care, while that's important, is really high quality, culturally competent primary care where they live. And that's how we get started here at Oak Street Health. We operate now 54 value-based primary care centers around the country, 3 of which are located in Rhode Island. And for that purpose, I'm delighted to be hosting this webinar with you. We have a lot to cover today, but to start, I wanted to highlight the 3 primary objectives. Number 1 is to understand what's the point of a healthcare system. Number 2 is to understand how the way that we pay for care affects how we give and receive that care. And the third is then examples of value-based models and how they impact the rest of the healthcare system. And hopefully at the end, despite a really ambitious agenda, we'll have some time for questions. And if you do have those, please put those in the chat and we'll do our best to address those at the end. So the first question is, what is health? And I know that's a big question to start with. When you Google that, or you spend some time looking at organizations try to define it, the Constitution of the World Health Organization has this definition highlighted that says, health is the state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And if you're like me as a clinician, I still have the privilege of seeing patients on Wednesdays here in Chicago, in one of our Oak Street centers. This is what that brings to mind to me. It's an unbelievably dream state that we would love to achieve, but it seems like with all of the things we're up against, it is, if not impossible, quite near impossible to achieve that for our patients. But I want to start by a little bit of a bizarre analogy, which is some data looking at the adoption of air conditioning, both in this country and then later around the world. And if you think that's a strange logical leap, I hope I can make it make sense, because it certainly made sense in the way that my brain works. If you look at this chart, what this shows is by region, by year, who adopted air conditioning first. And if you look, and I can sort of simplify this for you, hotter areas picked up on air conditioning first, but by the end, virtually everyone has air conditioning, and this puts this in graphical form. So there's this idea that we find new technologies that solve problems, technology being the application of knowledge to problem solving. We find new technologies, we find ways to make them more accessible, more affordable. People who need them first use them first, and then later on we see more adoption. And when you look, this is what we forecast for air conditioning adoption in India, thinking that 100 years from now, virtually everyone will have that air conditioning. Very few have it today. Well, the analogy that I'd like to make is that with value-based care. And the reason I say that is it is truly a technology. It is the application of knowledge to human problem solving. And we have a problem to solve, which is our healthcare system is broken. And I think what we will see is a similar adoption. But if I ask you what a healthcare system is, I would tell you that it's these 4 things. It is a payer, whether that's a government or an individual or a health insurance plan. There's a provider, a delivery system. And when I say provider, that means community-based docs and other practitioners, hospitals, specialists, diagnostics and imaging. And there's patients. And that value chain is really the way that we take care of patients. And then there are suppliers who I think of as manufacturers of drugs, manufacturers of MRI machines, of medical equipment. But when we talk about the system, this is the system. And then within that, the delivery system's the provider group, the way that the folks like myself, like the folks on the line, like us at Oak Street who take care of patients. So if you step back and you say, what's the goal of that? This is actually really tricky in an American context because we've not got a very clear stated goal of a healthcare system in the same way that the Veterans Administration has their own set of goals. The NHS in the UK has their own goals. Here, I think it'd be very reasonable for someone to argue that the goal of our healthcare system is very, very high quality, or that the goal is to cover everyone. We could argue that it's advancing science. One that is particularly provocative is this idea that over the last 10 years, the growth engine in employment in this country has been in the healthcare economy. And a big part of the reason that care is expensive is related to that. In either case, there are certainly folks in this country that argue that the healthcare system should be used as a source of employment. I won't answer that today. I think it's something for us all to consider what we want, and a good society is one that I think would solve that for us in a way that's coincident with our values. But here's the trade-off that we face in our healthcare system. You can pick where you want to be in this triangle, but as you notice, anywhere you go in this triangle, if you want to maximize access given limited resources, you will reduce quality and increase cost. If you want to reduce cost and you move towards affordability, you will decrease access or you will decrease quality. And this trade-off is certainly oversimplified, but a pretty good framework for how we need to think about our healthcare system. Well, if you think about that question, how are we doing? I've pulled together a few data points here that I think are helpful to demonstrate that. This is from the OECD. If you look at overall health spending, you can see that the United States spends substantially more than every other country in the OECD. And these are all places, if you don't want a vacation, if you don't want to live, at least you'd want a vacation. These are advanced, developed economies. And so this is really our comparison set. We spend far more. When you look at how we spend it, this is from HHS. Of the federal budget in healthcare, about half is Medicare, about a third is Medicaid, and the rest is smaller programs, but that's the way it's spent. If you look at quality, this is also from the OECD on a selected set of metrics, and obviously any one of these we can pick on. I certainly will pick on these. The blue triangles are where the United States is, so we spend substantially more. It's not clear from these evidence that we get substantially more for that money. We're either in the middle or towards the sort of low end of the pack, with the exception of life expectancy, which many would argue is not necessarily related to healthcare, but related to other features, and certainly you could argue that for many of these. In either case, we're spending more. We're not necessarily getting substantially more. And then when you look at access, this is taken from the Lancet from a few years ago. We are fine at access. We're certainly better than parts of sub-Saharan Africa, but when you look at our peers, when you look at Canada, when you look at Western Europe and Australia, we lag in terms of access to care. So the picture is not that we're horrible by any means. I think we're doing fine. I think, however, there's opportunity for improvement, and we're dedicating a lot of resources. We're spending a lot of resources on care that may not be getting what I would refer to as the value of care that we'd be looking for. And the interesting things, when you dig into national health expenditures, and if you ever have time, this is really interesting stuff that you can just Google NHE, lots of information to look at a national level, but we spend per capita about $11,000 in this country. The blue pieces there I've listed are hospitals, physicians, and essentially stuff that we spend on providing care. The rest, what I would call the delivery system as defined before. The delivery system's about 2/3 of that. So about $7,152 for every human in this country on the delivery system, meaning on providers. So this is a quote taken from a quite famous paper, in fact, on why our care is so expensive. It says, on key measures of healthcare resources per capita, hospital beds, physicians, and nurses, the U.S. still provides significantly fewer resources compared to the OECD median country. Since the U.S. is not consuming greater resources than the other countries, the most logical factor for the higher prices paid in the U.S. This is a lot of words to say the following, which is when you think about why we spend a lot, we're either doing a lot to patients or the prices are very high. It's price times quantity. And what this paper found, and it's been validated in a bunch of different ways, is that we actually don't do more to patients. It's the prices are far higher. I tend to like to make simplifying analogies. Just think about it this way. We don't eat more ice cream. The ice cream we eat is just far more expensive. The price is just higher. So the question is, why is it higher? Well, there's something different about the way that the price mechanism works in healthcare than in other markets. And I'd be the first to say, this is by no means intended to be a free market. I don't think anybody necessarily wants that. And certainly there are outliers who want it to be a totally free market. But these analogies and the studies of these markets actually help us as physicians and as clinicians to get a better sense for why this behaves in such a bizarre way. Number one, it's what economists would call a luxury good, which means the more money you have, the more you demand of it. So as we get wealthier as a society, we are going to want more healthcare. The other thing is it's the other people's money problem. Individual patients are often not the payers. There's another payer in the way. And so there's a little bit of spending other people's money that creates more demand, will drive prices up. The third is that there's an information asymmetry. And another way of saying that is you don't necessarily know what you're getting. As a patient, your doctor will, or your nurse practitioner will recommend something, and you don't have any way to describe whether that's exactly what you need or not. And so you tend to just trust that person. The next thing is that what people will treat you as, quote, pseudo infinite demand, but this is the idea that you get to live one time, and healthcare is one of those things that is supposed to allow you to keep living longer. And so at the very end of your life, if you could go back to have perfect health, you would pay everything you possibly could. And the last is something that is really uniquely noticed in healthcare, which is the idea of if you build it, they will come. Communities often don't need 2 hospitals, but if you build 2 hospitals, that hospital will be full. That's part of the reason that many communities have what are called significant certificate of need requirements before you do build substantial healthcare facilities. But all of these things will increase demand, which drives up prices. On the supply side, things are hyper local. There really is not translation across markets, meaning when we take care of patients in Rhode Island, what happens in California doesn't necessarily affect us, and it constrains supply, which drives up price. And then the last is around labor controls. There are, for very good reasons in many cases, but other reasons maybe not so good, a limited number of physicians, a limited number of nurses, a limited number of the trained folks who can do this work, and that drives up the price. And I share this with you because if we decrease the supply and we increase demand, we shouldn't be surprised that we see higher prices. And you'll notice that this list that I showed you, some of these things are unique to the American context, some are not. And I'm actually not making a point in describing this. What I'm really trying to say is that there are reasons built into the human experience and the way that we take care of patients that are going to make prices higher. And so we need to think about creative ways to make it an appropriate price. So what does this mean for our healthcare system? There's a really unique paper published several years ago in the Annals of Internal Medicine called The 8 Basic Payment Methods in Healthcare. I would encourage you to look for it. But there's a chart there that really simplifies the whole thing, which is to say, forget what we want, forget what we need, forget what we do. There are 8 really unique and differentiated ways to pay for healthcare. And depending upon the way that you pay, you're going to get different behaviors. So you can pay per time period, per beneficiary, which would be a capitated model. You could pay per episode, which is like a bundle. You could pay by cost. You could pay per diems. Per service tends to be the most common, the fee-for-service methodology, which is related to CPT codes and RVUs and things like that. The important thing to know is regardless of what you want or what we currently do, changing how you pay for things is going to change what we get. So here's a quote from that paper. It says, "No payment method is neutral on quality because each encourages and discourages the provision of care overall, and in particular situations. Many professional norms and business practices have been established to mitigate undesirable incentives. Healthcare differs from many other industries in that the unit of payment remains variable and unsettled." I think that's a really nice way to tee up the conversation today as we transition into thinking about value-based payment methodologies. Now, I've included this. If you squint, you can see at the bottom probably what this is, but if you want to guess, this is a photo of the original tablet upon which the Code of Hammurabi, the first human set of laws, was put into stone. And there's an interesting one on here that says if a builder builds a house for someone and does not construct it properly, and the house which he built fall in and kill its owner, then the builder should be put to death. Now, I'll be very clear, I've made plenty of mistakes in patient care. I am not at all suggesting that be the penalty. But there is this idea of moral hazard, and whether you're a legal scholar or an economist or a clinician, there is this idea of tying outcomes to the inputs and creating accountability. And there's a question of how much accountability should we have in various parts of human endeavor and in our economy. And what's interesting is certainly it's very reasonable. We hold certain market participants accountable and others not, and that all makes sense. And I think we should all be open-minded to that. One of the conversations we're having now as a healthcare system, not just in this country but globally, is the degree to which healthcare entities, clinicians, patients should have accountability in the process. That's a really nice transition to this idea of what is value in healthcare. For those of us, and I spent a good chunk of my life in New England, if you go up to Boston, there's a gentleman there named Michael Porter, who is a university professor at Harvard and teaches in the business school. And he came up with a framework about a decade, maybe a decade and a half ago, that value in anything is really the outcome divided by the price. It is the quality of the meal at the restaurant divided by the price. It is the quality of the outcome that the patient receives in combination with the outcome he or she experienced divided by the price. So the goal then is better outcomes at lower prices. And if we think about this really as a quotient, our goal as clinicians, and my guess is every clinician on this call went to medical school or to nursing school or wherever we went to school with the goal of delivering the best outcome we can. And we're going to need a lot of help doing that. In the same way, we're going to need a lot of help from our colleagues to deliver a lower price, an affordable price, something that our friends and neighbors can afford. And CMS refers to value-based care as paying for healthcare services in a manner that directly links performance on cost, quality, and the patient experience of care. What that just says, and tying back to the paper we just looked at, is how we pay for care affects the cost and quality of that care. And I don't want to go through necessarily this table directly, but one of the things that I'd encourage you to afterwards is read this and really compare the model that we live in today, which is fee for service, that idea that a provider provides a service and a patient pays a fee, and compare that to a value-based model. In fee for service, if we do the work, we get paid for the work, regardless of the outcome. In a value-based model, what we're trying to do, and it's not just me, it's not just us at Oak Street, it's not necessarily just CMS, it's all over the world, in the NHS, in the German system, in the system in the Netherlands, really trying to create a value-based model so that what we get is what we really want, which is value, not necessarily output. And it's fair to say this is happening quite quickly. So Administrator Verma, who's the administrator of CMS's Center for Medicare and Medicaid Studies last year, said, if your business model is focused merely on increasing volume rather than improving health outcomes, coordinating care, and cutting waste, you will not succeed under the new paradigm. And I don't think she is being provocative there. Interestingly, regardless of where you fall in the political spectrum, she is really continuing work initiated in very early days, really in the 90s with the advent of Medicare Plus Choice, which later became Medicare Advantage, later became the ACO, and now a very, very different administration is doing very similar work. And if you look, what you see at the table at right, and this is from Health Affairs, is that over time there's been a really dramatic increase in accountable care contracts over time, and there's no expectation we'll see that stopping. So how do we think about this? When you really think about fee-for-service versus value-based models, you can think about it really as a death spiral. That's what we call it here. And if you start at the top of that, the number one thing that you would try to do in a fee-for-service model, this is not to us as clinicians, this is just the incentive that exists in that model, is you'd want to drive more volume, more visits, as we would say. If you do that, if you move from where you had 30 minutes with a patient or 4 hours to do a procedure or whatever it would be, obviously, if you shrink that over time, the argument that many clinicians will make and has been demonstrated in literature is that you will see lower quality. Then from there, that means that you will reduce quality. It will require more expensive downstream interventions, whether that's in the form of reoperations, rehospitalizations, or more services required. That later increases cost, which requires rate cuts, which leads the system to demand to keep up that revenue, more visits. And you get into this spiral of more, lower quality requires more, higher cost, rate cuts requires more, and the spin goes on forever. And if this feels very familiar, it's because it's what we've seen over the last really 75 years since the advent of a national fee-for-service rate book. Flipping over now to thinking about value-based models, we think about this as a virtuous cycle. So if you start at number one there, you make an investment in quality. That improves outcomes. That drives more patients into those models. You save money by reducing hospitalizations, reducing the need for later services. That creates a surplus, and those surplus can be reinvested. And this has been demonstrated in a lot of settings. here at Oak Street, of course, but in a lot of other models that look, in many cases, quite similar, but in many cases quite different. But it gives us this idea now that we can invest in services that we as clinicians want to provide, that our patients need. We can improve outcomes, which is our goal. We can reduce the overall cost of care by improving quality. And that is not true in all populations, but it is certainly true in the complex chronic populations that really drive the majority of spend. So I do want to be intellectually honest and say there are certainly populations that for whom this will not work. And I think those are, frankly, some of the most interesting things for me to talk about. And I'd love to explore that with many of you. But in the large populations of complex chronic illness that really drive healthcare spend in this country, there are material opportunities for savings that we see savings in that make these models work. And frankly, the savings in that population, I am of the belief it would allow us to make the sorts of investments that we would want to improve equity and improve overall quality in those populations for whom this model does not work. That being said, in the population that really drives cost of care in this country, it does work. And so what are the keys to that? And this is true now across the National Health Service in the UK. It's true across things like Kaiser Permanente, which is a fully integrated value-based model, obviously, largely on the West Coast with some other outposts. And here at Oak Street, you need 4 things. You need attribution. And what that means is patients need to be ascribed to an individual provider so that patient and provider knows who is responsible for his or her care. The second thing is it needs to be prospective. You need to know that ahead of time. You can't be told after the game what game you're playing. You need to be told ahead of time. The third is it needs to be risk adjusted. And it means that we need to be able to pay more to take care of sicker patients, because if you don't do that, it very quickly becomes a race to get away from sick people and cherry pick. And that is obviously not what we want in a healthcare system, not here in this country, not in individual practices, not in individual states. It's not what foreign governments are trying to do with their models either. And the last is you need quality metrics, because providers need to measure and report on the quality of outcomes and have to meet certain performance levels. The goal is not to save cost at all cost. The goal is to save cost in the setting of improving quality, and these quality metrics allow us to do that. And again, I know many providers who may not be used to these, and certainly there are weaknesses in a lot of measures. That being said, composite measures across a diverse set of measures generally are well received. And frankly, this is an opportunity for clinicians to collaborate with non-clinicians on the measurement of these things. And certainly if folks are interested, that we can make that a topic for a future webinar. So I want to go through a few examples of existing models of value-based care. We're going to talk about ACOs, we're going to talk about Medicare Advantage, and I want to make some comments on a new model, which if you haven't heard about it, will, I think, fundamentally change the way we think about the way that we interact with Medicare and Medicare patients. So this first I want to dive into is a paper that was published through a consortium at a consulting firm. It's also worth saying that one of the authors of this is a member of our team here at Oak Street, and so this is part of the reason when we initially started the organization, we were informed by this data. If you look at this, Medicare Advantage, just to pause before I go into this, Medicare Advantage, for folks who don't know, when you turn 65 as a Medicare beneficiary, you have 2 options to receive your Medicare benefit. Number one is through what's called traditional Medicare. You get a card that essentially acts like a coupon. It's a co-insurance, and it's 20% off virtually all of your healthcare. You still have to pay the other, it's 80% off, so you have to pay the other 20%, but 80% is covered. In many cases, that works quite well. It is not true insurance, however. It does not have catastrophic coverage. There's no maximum out of pocket. There's no network. It does not act like an actuarial product. It was designed with very good intentions in the 60s in the administration of Lyndon Johnson. Very hard to judge those folks at the time because they created something that nobody had ever seen before. But it's a quite old product. In the 90s, something called Medicare Plus Choice came around. It was renamed and updated in the 2000s to be called Medicare Advantage. And what this means is, as a Medicare beneficiary, you can say, instead of getting your 80% off coupon, what you would like is an actuarial product. It is provided by all of the many same insurance companies we've heard of, the Blue Cross Blue Shield plans, Humana, Aetna, Cigna. There's a whole bunch of them. I can list them all. I will not. In Rhode Island, it is provided by Blue Cross Blue Shield of Rhode Island and Humana and several others. Actually, I don't believe Humana, but anyway, what this means is a Medicare beneficiary asks the government simply to send a check to the insurance company, who then gives them insurance. The government buys you insurance based upon your selection. And what makes it different is now, instead of being able to go anywhere, it acts like normal insurance, like commercial insurance that the rest of us would have, meaning there's a network. It's either a PPO or an HMO. There is some cost sharing, but they're out-of-pocket caps. And the interesting thing is, this has been looked at now on both sides of the aisle. Turns out it's been incredibly popular. It's grown like crazy. About a third of Medicare beneficiaries get their Medicare this way. But it is now an actuarially based product that has prior authorizations, that has a network, that has quality metrics associated with it, and as a consequence is looked at as a more integrated way to receive Medicare. This study looked at comparing various flavors of Medicare. And what they looked at first here was compare Medicare Advantage to Medicare in an acuity match population. So this has been corrected for acuity. There are good academic studies that look at, because in small ways, it does look like healthier patients are able to more engage in this decision and therefore choose Medicare Advantage. But this is an acuity match population that found, if you look across the bottom, FFS stands for fee for service. That is a fee for service traditional Medicare patient. PPO is a Medicare Advantage patient, so now not traditional Medicare, but this person does not have a network. So they can go wherever they want. There's just a little bit more coordination and quality metrics. The HMO means that this person is a Medicare Advantage patient now with an HMO. So there's a network really tidying up who are the providers in the network and not, and constraining certain services through the use of prior authorizations. And then the fourth category, CAP, stands for capitation. That is using a model where that patient is an HMO patient who is ascribed to an individual provider who has a capitated agreement where they are paid to manage the cost and quality of that patient. Think about it this way. CAP means that PCP has a budget for that patient and is going to obsess over the way that that patient navigates the healthcare system. So I'll say this over again. FFS is traditional Medicare with no network, go wherever you want, free for all. PPO is Medicare Advantage, but there's no network, still a free for all, but there's quality metrics in it. HMO means that it's now there's a network. It's Medicare Advantage, but there's a network. You can only go to certain places and there are constraints on it. And a CAP is an HMO, but now your primary care doc is totally aligned with you and gets all of your quality metrics and frankly needs to improve your quality and lower your cost, or their model doesn't work. So you can see there's sort of a spectrum here from left to right moving towards a more managed model. And when you see there's been a really significant reduction in emergency department visits. Looking at the same progression from fee-for-service to PPO to HMO to capitation, length of stay in the hospital went down and 30-day readmissions went down. And the one thing that I'll note here is when you look at that readmission rate, the national average is going to be somewhere in the 15-16% range. This is far higher, which demonstrates this at baseline is a far higher acuity population, but you still see shorter length of stay and fewer readmissions. What you also see, however, is more preventive care, more investment in A1C tests throughout the year, and more investment in nephropathy screening. And this is a really important thing to find, because one of the things that you may imagine, that you may hypothesize, is that in this model, providers may skimp on care to try to save money. And what you see is quite the opposite, because they recognize the value in investing upfront. Now, when we get into outcomes-based measures, I think the most important thing you'll see here is on the left-hand side is diabetic amputations. This went down by a relative risk reduction of over 98% in these models, because now there is data and reporting and full accountability on these. And you see, essentially in these models, we stop cutting off people's feet. Now, this is a really striking way to report this, but this is going to be far more important than any revascularization, any drug, any of these other things. And it's crazy to say that, but if the intervention is we're going to enroll people in these other models, this is going to turn out to be, I would argue, and the data now suggests, far more powerful than any clinical intervention we could make. And you see the same in foot ulcer procedures. And this is where the summary of all of this, and this is, I think, the most provocative page in all of these materials, is to suggest single year mortality goes down when you move across the tenure, enrolling patients from a PPO to an HMO to a capitated model. And what's interesting is that is far truer for higher risk patients, meaning finding an attributed primary care doctor who is fully aligned with patient interests not only reduces mortality, but especially reduces mortality in higher risk patients. So I want to talk a moment about Oak Street just as a quick introduction. This is not intended to be a commercial, but more to give you context of how we think about it and how we hope other practices around the country will begin to think about it. We started the organization in 2012. We're a network of primary care centers focused on patients with Medicare and Medicaid. A really substantial portion of our patients are dually eligible. We're focused really specifically on rebuilding healthcare as it should be, and that includes evidence-based care, health equity, and provider accountability. We have 54 locations now in 8 states. We have centers opening in Tennessee, and that would be our 8th state not listed here. There's about 250 primary care providers in our medical group, really diverse group of physicians, nurse practitioners, complemented by some other specialists in psychiatry and other things like that. We've had the privilege of taking care of over 100,000 unique folks over the last nearly 8 years. Well, I've been doing this for 7.5 years, so almost 7 years of taking care of patients. Very structured in how we think about taking care of patients and engaging a community. We build centers in communities where nobody knows us, really focus on communities where there's very little primary care access. We work with community partners and other practices, whether they're primary care practices or specialty practices, hospitals, post-acute facilities. But the goal is to go to a community, engage patients, educate them on primary care, invite them to engage in a primary care model, and then enroll them in an evidence-based care model using integrated care teams, a lot of intensive programs to support the needs of our high-risk patients, and try to fill gaps that a traditional healthcare system can't provide. We think a lot about patient experience. That starts obviously before patients become patients at Oak Street by doing community outreach, working with community organizations, faith-based organizations, municipal governments. We do a lot of work with food pantries and homeless shelters, really to engage ourselves in the community, invite folks to get to know us. Every one of our centers has a community center. You are all welcome to swing by any of our community centers anytime. There tends to be a couple of events every day in the center, really largely focused on our patients and their families, but everybody's welcome. It's things like, bingo and senior speed dating, and having aldermen come by and talk about what's going on in the neighborhood, doing lectures on breast cancer screening, celebrating holidays, whatever that may be, but would encourage you all to come by. Once we do that, really the goal then is to educate patients on their Medicare and Medicaid benefits, on primary care and how it works, and how we can help them navigate the healthcare system. And then the last is really to provide a concierge level experience for folks who justifiably have reasons to not trust the healthcare system and have had lower expectations. We try to encourage them to raise those expectations and meet those expectations. As you can see, these maps here demonstrate, this is a map of Chicago. On the left is the darker blue areas are higher income, the lighter areas are lower income. And then on the right, the green is areas of primary care concentration versus not. So as you can see, we are really focused on solving the problem of creating access in low-income communities. And this has been the theme from the very beginning. We do this in Chicago, Detroit, Indy, Philly, Cleveland, and around Providence now. We have 3 locations in Rhode Island, in Warwick, in South Providence, and over on Branch Avenue. Like I said, would love for you to come by and see us. You're welcome just to drop in and say hello, and would love to get to know anybody in the community. One of the things for clinicians that I'd like to talk about just a little bit is the way that we think about the patient journey. We're highly structured in how we approach this, and increasingly this is coincident with the peer-reviewed literature of structuring care in a way that is both repeatable and consistent. When you look at really all the literature on what drives high quality, high safety outcomes, it comes from high quality, high safety process, and that's how we think about it. So at the intake and assessment phase, we have face-to-face visits, really doing structured geriatric assessments using evidence-based screenings, both for screening and diagnostics. There's a list of those below, but really grounded in the evidence to be sure that every patient gets their evidence-based screenings. And then do a lot with both our internal data systems, but as well as those from CMS like Blue Button and health information exchanges and payer claims from our payer partners. To load those into our enterprise data warehouse, and then we apply a quite sophisticated machine learning informed risk stratification module that we found now, because we have so many different data sources and a patient relationship, that our models now outperform the commercially available models in terms of risk stratification and understanding who's at risk and what the care gaps are that we can fill to address that risk. We combine that obviously with the wisdom and experience of our care teams, which is far and away the most expensive and most valuable thing we have, to create a longitudinal care plan. And that's where we are at top. And really there, what we do is we, quote, dose the primary care. Higher risk folks are going to see us more often than low risk folks. They have an interdisciplinary care team. Every one of our care teams includes a physician, a medical assistant, a full-time scribe. And if you're interested in the scribe program, we published this experience in the New England Journal of Medicine Catalyst a few years ago. So you could just Google Oak Street Health, New England Journal of Medicine Catalyst, and you can see that. But the team, in addition to the scribe, has a behavioral health specialist, a medical social worker. That group is going to work within evidence-based guidelines to see our patients really as often as as indicated, and really to try to drive our outcomes. Our average team is going to have a patient panel of about 500 patients. That compares to the national average panel size for a primary care doctor of about 2,500. So it's a far more intimate practice. On average, we see our patients 9 times a year. That compares to the Medicare average of 3. Visit lengths are materially longer. The National Ambulatory Healthcare Survey from the last year, in which we have data, puts the median visit length at about 17.4 minutes. At Oak Street, it's closer to 30 minutes. So really an intimate practice supported by a lot of population health tools, data tools and dashboards, and frankly, time to sit down with your team and do daily huddles, weekly planning meetings, and monthly reviews of outcomes to really support the kind of practice that I think we would all want to have. Within that, we have some really specific population health interventions listed below. Some of the most important ones I describe are our integrated behavioral health model, which is based upon the impact model for folks who are deep in that literature. We do home-based primary care in certain settings for homebound patients. Medication management, have an in-house pharmacy team and a lot of work, including a lot of data support to be sure that patients are on evidence-based regimens and get those. Support with social determinants through our medical social work and our patient relations management programs. We have 24/7 clinical contact centers. So if you call any of our centers, it won't ring in the center. It's very quiet in the center, in fact. But we have 24/7, 365 nurse coverage to help our patients with access. And then local teams who will get out when a patient, for many good reasons, may lose contact with us, may have some challenges in life. We're able to try to go out and really help support that patient where they are. And then when folks obviously do have to leave our centers, whether it's to go to the hospital, go to a specialist, go to a post-acute facility, we do a lot of work to help coordinate those services. So that sort of gives you the framework of how the care model works. I do want to mention a little bit around our technology model, because increasingly, and I think this is such good news for primary care and for our healthcare system, folks are recognizing the important role. This is, again, outside of Oak Street. The important role that primary care plays in our healthcare system at large, in delivering health equity and improving outcomes, and frankly, improving the provider experience for those of us who take care of patients. Data is an important part of that, because we're stuck banging away on computers rather than allowing technology to help us solve our problems. We really think about this as sort of a 3-part framework of data, insight, and action. On the left-hand side, it's collecting all of the data from all of the DERS sources, big data, obviously, and that's a buzzword, but little data, highly personal, timely data from our patients. Loading that into a warehouse, because data is just data. What you need from that is insight. And we have found, others are finding, we at Oak Street have certainly found that the application of advanced data science to generate insight is one of the most important things we can do, because it means that rather than you searching through the chart to understand whether somebody needs a mammogram or not, we can tee that up to your care team so that without you even knowing, your care team with guidelines that I and the medical director team have signed off on can take action, can get a fit test ordered without you having to take any action, and your time is spent building a relationship. But that comes because we have the data, we've generated the insight, and those actions are delivered within care team workflows at the point of care. So they can take action, you and your care team can take action through what we call Canopy, because it's a cute arboreal metaphor, which we're big on at Oak Street, but that is the web-based tool that we use to support our patients at the point of care. And I share that with you because that's what we see the rest of the frankly, the practice industry going towards. Having tools that look less like self-serving EMRs for billing purposes, but tools that should support us in our practices. And it's things that, again, if you can't already tell, I'm quite the optimist about American healthcare and about what it feels like to take care of patients, especially for those in a primary care setting. And I think this is just an example of that. So to begin to wind things down, I want to share with you just a little bit of what this has meant for our patients. Our average patient at Oak Street is quite complex. The average patient is a she. We are more women than men. She's 69, though our age ranges from 20 to 103. 23% are under age 65. So we do focus on Medicare, but quite a bit are under age 65. That dual status is 28%. It is materially higher now as we grow in lower income neighborhoods. Average income is $21,000. About a third have a behavioral health disorder. About half have a social factor that is going to negatively impact their health. The average reading level is 6th grade, and we practice in 7 languages, really speaking to the diversity of the patient population that we take care of. We talked about the model, but the results have been really striking. And there's nothing, listen, I think we have an unbelievable team at Oak Street, but I think this is something that we can all achieve as we look forward to a better healthcare system in this country equipped with these tools and the kind of structure that we have in our value-based model. About a 41% reduction in hospitalizations, about a 50%, 49% reduction in ED visits, and 5-star quality for patients who've been with us for a year, meaning they've had the full exposure to our care model. I think that's all really good news. And it's also good news for our providers. So one of the things that I am particularly motivated by is this idea that we can change what it feels like, not just for patients, but for providers who take care of patients. If you haven't seen already, we're really structured, and I and our medical group are quite structured in how we think about the provider life cycle at Oak Street. We think about it like this. We welcome new providers, which includes many of the residency programs that rotate with us. We do a lot of training with our new nurse practitioners. We actually have 2 fellowship programs at Oak Street. One, our newest fellowship program, is in partnership with Northwestern University and the Kellogg School of Management, in which it's a 2-year program. New trainees and some experienced folks, in fact, come back. They work with us at Oak Street. They have a patient panel. They see patients 3 days a week, 2 days a week in the fellowship program. They rotate through various teams at Oak Street, our population health team, our care navigation team, our clinical quality team, really learn how this value-based model is put together, and then get a fully subsidized Kellogg MBA as a part of the program. We do a lot of work, open houses, to try to welcome folks, and webinars like this one to have people get to know us. If you're interested in learning more about Oak Street, obviously you know how to find us, and my email address is at the very end of the deck here, but you can certainly reach out to us on our website. But try to do a really good job letting people get to know us, and if this is the right place, having them join us. When they do, supporting that onboarding with orientation, mentorship, and team training. Once here, we have what we call the Joy in Practice program, which is really trying to improve overall wellness and, frankly, what it feels like to take care of patients. One of the things that we'll talk about in a little bit is a recognition that we received for that work. But we have a really happy group of folks here taking care of patients because we just do what we do. It's focused on primary care and focused on supporting providers in the work that they do to support patients. A lot of support from the medical leadership, and like I said, every provider here has a scribe whose job's to take on some of the nonsense we face in a traditional practice, and complement the technologies we have to support our practice. We focus a lot on development and practice improvement, and really supporting our own personal growth. We shut the practice down a few times a year and have grand rounds, fly everybody here to Chicago. We did it last month. Had leaders from HHS, from the Cleveland Clinic, and really elite speakers coming to teach. We do a lot of continuing medical education. We offer executive coaching for folks who are interested in leadership positions. And one of the real challenges for us as we grow is, how can we build homegrown teams of enlightened leaders who can be our clinical leaders here at Oak Street for our primary care docs and our teams. And really at the end is to delight our teams, to have not only a good experience, but reduce turnover, have high retention. And one of the things that we find is our physician turnover is about half the national average, and over 90% would recommend Oak Street to their friends and colleagues. from residencies a place to practice. So we think about this in a very structured way. We do a lot to work with other practices to help them think about this, because we really want the experience of being a doctor and a clinician today to be better, and to share the way that we do that. As a part of that, we were one of 22 groups recognized in 2019 for the Joy in Medicine recognition. When you look at this, it's the BI up in Boston, it's Mayo, it's Northwestern, it's really elite organizations, and as we like to say, Little Oak Street Health here, and hope to keep that going. And obviously, if you and any of your organizations are interested in this, we'd be delighted to sort of share the process and some of the learnings, and hope that, frankly, for the benefit of providers around the country, that there can be more groups recognized this way. We've got now about 10 minutes left, so I'm going to pause and see if there are any questions, and do my very best to take those. And I'll take this moment to say, I sure appreciate you all joining, and hopefully look forward to getting to know you. And this is my email address on the screen. So reach out with anything, and we'll pause for a moment for questions. I think the best way to do questions, by the way, may be in the chat. So I'll just keep the chat open for a couple more moments here before we wrap things up. Seeing no questions, I would say I do invite folks, please email me. It's listed right there. It's griffin@oakstreethealth.com. If you can't tell from the tone of the conversation today, I'm incredibly optimistic about what it feels like to be a clinician, especially in primary care, and a patient, especially in primary care. And I do very much think that we have sort of reached the hardest moments in primary care in our country, and have so much to look forward to, and so much momentum, so much support from CMS, and I just look forward to working with you all on this, and hope to hear from many of you in the future. So thank you so much for your time. We'll wrap it up here, and hope you all have a great day. Thanks so much.